So by way of full disclosure, I'm faculty at the University of Texas Medical School in Houston. My primary appointment's in the Institute of Molecular Medicine. So through a series of discoveries, we've been able to commercialize it. We formed a company through the University of Texas. And so typically what I'm required to do is differentiate my academic directed lectures versus my commercial entities. But today I'm actually wearing both hats, so I want to make the clear distinction, and so you can interpret that data then accordingly. So those of you who've never been to the Texas Medical Center in Houston, it's basically a city within a city. So this is recognized as the world's largest medical center. Can't hear me? Okay, I'll speak up. So the Institute of Molecular Medicine is here in this building on South Campus. So we really have enormous resources available to us in the number of hospitals, number of unique patients that we can begin to see and collaborate with the clinicians. And really, I think that's been the basis of a lot of our discoveries, this cross-collaboration between clinicians, basic scientists, and really integrating unique patient observations and bringing that back to the lab. So in the medical school, we always teach to go from bench to bedside, or translate medicine and discoveries. But really, the paradigm we've worked on in the medical center is taking bedside to bench, back to bedside, trying to understand unique patient observations, but then modeling that in the lab, and then trying to develop rational therapeutics to affect these particular patients. And so for the next 45 minutes, I've divided this up into basically 4 components, and I'm going to get everybody on the same page and describe what is nitric oxide, why we think this molecule is really important. I'll show you a few studies that we published on the role of NO in health and disease, and really what led us to the discovery of this concept and this technology we developed. And then how to diagnose nitric oxide insufficiency for the manifestation of symptoms or disease. How do we get a handle on this? And then I'll end with showing some studies where we harness some nitric oxide activity of plant-based products and develop this into a novel therapeutic. And again, in the interest of full disclosure, you should know that I'm the founder, chief science officer of Neogenis Labs. I've been consulting for Bristol Myers Squibb, and I'm the stock owner and advisor for Sage Pharmaceutical, which is developing small molecule drugs. And this is what we've been trying to get at for a number of years. And so where modern medicine does a very, very good job for acute illness, if you have a car accident or if there's a broken bone, the emergency medicine is really good for acute, but really chronic illness, it's an utter failure in terms of treating chronic disease here in the U.S. And we know that most of these, we've appreciated this for a number of years, that most chronic diseases are preventable by diet and lifestyle. But yet compliance is an issue. So we know we're supposed to eat the right foods, we know we're supposed to exercise, but yet no one does. And so hopefully by the end of this, I'm going to convince you that really what we've discovered is still diet and exercise, but understanding really a physiological and biochemical component of certain foods and the benefits of exercise that all trickle down to this molecule, nitric oxide. So what is nitric oxide? It's a very simple molecule, very simple, in fact one of the simplest in nature. It's 1 nitrogen, 1 oxygen. So this dot here is a free electron. So and most people consider free radicals, as they're called, as toxic damaging compounds. But this nitric oxide molecule, being a free radical, is actually antioxidant in nature because it actually scavenges other more toxic, more damaging free radicals. And it's recognized now as one of the most important signaling molecules in the body. It's a gas produced by our blood vessels. I'll show you a schematic a little later on, but it's produced by your blood vessels, and it tells the blood vessels to relax and dilate where you can increase oxygen and nutrient delivery. Before the 1980s, it was recognized as a toxic air pollutant, and it was actually measured in exhaust of automobiles as a measure of incomplete combustion. So you can imagine the change in paradigm when it was recognized that what was once thought a toxic molecule was actually produced within our body, and it became a very important molecule. It shouldn't be confused with nitrous oxide, so that's probably the most common misnomer. That's the laughing gas, the anesthetic you get when you go to the dentist office. Although they sound very similar biochemically and physiologically, they have completely different functions. Next slide. And we now know, with over 130,000 papers published on nitric oxide, that it's involved in basically every biological function known. There's really not a biological system where nitric oxide has not been implicated as an important role. So in immunology, it's the molecule responsible, that's produced by our white blood cells that kill off bacteria and viruses. In the cardiovascular system, it's responsible for maintaining normal blood pressure. It also prevents plaques and white blood cells from sticking to the blood vessel lining, so it keeps your blood vessels really clear and free from plaque buildup. It's responsible for mediating non-adrenergic, non-cholinergic signaling in the periphery and in the gut. It's a neurotransmitter in the central nervous system. And in fact, there's a clear association now between Alzheimer's, pre-Alzheimer's, and mild cognition disorders and an insufficiency of nitric oxide. It's also a molecule that regulates apoptosis, or when you have rapidly dividing cancer cells, nitric oxide can actually shut down this replication and kill off early cancer cells. And it's also the main molecule responsible for sexual function, erectile dysfunction, or sexual function in both men and women, where you have to get a dilation of the blood vessels in the corpus cavernosum to get and sustain an erection. And in fact, I'll show you that's the mechanism of action for drugs like Viagra and Cialis. And as Dr. Ross said, the Nobel Prize was awarded in 1998 to these three gentlemen, and it was really the collective efforts of these, because Fred Murad in 1977 discovered that nitrovasodilators such as nitroglycerin and organic nitrates work through the release of nitric oxide. So before that, these drugs were used for over 150 years, but nobody knew how they worked. They just knew they did work. And then in 1980, Bob Furchcott really had a very similar discovery, and he discovered that our endothelial cells produce this substance that dilates blood vessels. He didn't know what it was and couldn't identify it. So he called it endothelium-derived relaxing factor, a very vague name because it was basically just, that's what it did. And then it was Louis Ignarro in 1987 who discovered that EDRF, or this endothelium-derived relaxing factor, is nitric oxide. And really it's one of the quickest awarding of a Nobel Prize from time of discovery to the awarding of Nobel Prize. So Nobel Prizes typically you got to stand the test of time, and sometimes it's 20, 30 years after the discovery before the Nobel Assembly actually says, okay, this is true, it stood the test of time. It's important enough to award. This was a short 11 years after it was actually discovered that the Nobel Committee awarded the prize. And as Dr. Ross said, I have to, Bob Furchcott's since passed, but Louis Ignarro has written a foreword to two of my textbooks. And then I was recruited by Fred Murad in 2005 to join his group within the University of Texas Medical School. And this is a schematic. If you can appreciate, this is the inside of a blood vessel. And these are what we call endothelial cells. These are single cell layer of cells that line every inch and every centimeter of your blood vessels. And so when you have an increase in shear stress, for instance, when you begin to exercise, you need to dilate those blood vessels to accommodate more oxygen and more nutrients to the working skeletal muscle. And so what happens, you get an increase in shear stress, and then that tells this cell to make nitric oxide because it needs more oxygen and more blood flow. So when this nitric oxide is produced, it will actually diffuse, and so this is a muscle layer that lies beneath these cells. And then if you'll hit the next slide. What happens is nitric oxide then will activate a second messenger or bind to another enzyme and then activate the second messenger cyclic GMP. Then this actually tells the blood vessels to dilate, or these smooth muscles to relax. And then by the action of, if you can prevent the degradation of this second messenger, you can actually enhance this effect. And that is really the mechanism of action, and where drugs like what we call PD-5 inhibitors, like Viagra and Cialis, work to prevent this degradation of this signal. And so it's estimated that only about 50% of the population will respond or see a benefit from drugs like Viagra and Cialis. And the reason for that is you need some level of nitric oxide produced by these endothelial cells to turn this signal on that then drugs like Viagra can keep on. And so without any basal level of NO formation, these drugs have no substrate and no target to act on. So with nitric oxide formation, these drugs actually work. And in fact, that's the reason for the warning against 4-hour erections and the reason for avoiding organic nitrates such as nitroglycerin when you take it, because then you can overwhelm the system and you'll get systemic vasodilation and run into some very serious problems. We now recognize that nitric oxide has many clinical implications. Again, the clear association now between nitric oxide deficiency and Alzheimer's. Really the only therapeutic indication for nitric oxide-based therapies is in inhalated nitric oxide therapy for premature babies born with pulmonary hypertension. So usually the lungs are the last things to develop in utero. So premature babies will a lot of times be born with insufficient lung formation. They'll get pulmonary hypertension. And so you can completely overcome this by giving these babies inhaled nitric oxide therapy. And this technology saved hundreds of thousands of babies' lives, allowed them to live into adulthood. And to demonstrate proof of concept, this was taken from the Nobel website, from what Dr. Myriad had discovered. And so you can appreciate this as a coronary blood vessel, and you get plaque buildup over time from years and years of poor diet, poor lifestyle. And so what happens is this plaque begins to build up, and then they've covered that single layer of endothelial cells, as I showed you earlier. And then so these blood vessels can no longer respond to normal stimulus. And so they can no longer get nitric oxide production. But if you give a drug like nitroglycerin, which is a spontaneous nitric oxide donor, in the lumen of the blood vessel, it can deliver nitric oxide and still tell that smooth muscle to relax and dilate. And so this is why these types of drugs are very, very effective at relieving symptoms of acute angina. So when you have the chest pain due to constricted coronary arteries, you can give sublingual nitroglycerin or a dermal patch and dilate those coronary arteries and get complete symptomatic relief within a matter of minutes. The problem with those class of drugs is you can't use these chronically because it's known that you develop tolerance of these types of drugs over time. And they become ineffective, and outcome studies have shown that people actually do much poorer taking organic nitrates such as nitroglycerin chronically. So again, a very effective acute strategy, but not effective for chronic disease. And this is the only biochemistry slide. I don't want to scare you away. If I get too detailed, please tell me let's do this. But I think it's important to understand the paradigm at which we now operate and how do you make this molecule nitric oxide. And so if you can appreciate this as an inside of a cell, so for the long time people thought that there was just a black box, that if you give L-arginine, you would get nitric oxide out at the other end. But without understanding the complexity and the context of how that reaction goes, we've missed a lot of important components, and in fact, in some clinical trials have done more harm than good. But to appreciate the complexity of this, and without getting too technical, to turn L-arginine into nitric oxide is probably one of the most complicated reactions in the human body. It's what we call a 5-electron oxidation. So you can take this nitrogen component here that we call this guanidino nitrogen, and then make nitric oxide, and then you get L-citrulline, another amino acid, as a byproduct. And then once nitric oxide is produced, we've recognized recycling pathways, combined to glutathione, the most important antioxidant in the cell, and then this molecule can actually transport nitric oxide activity. But there are a number of things that can go wrong with this reaction in this enzyme. For instance, you can have insufficient L-arginine uptake into the cell. This enzyme can become uncoupled and actually produce more toxic oxygen radicals and actually make things worse, so it actually exacerbate any condition that you're trying to improve. And so we've struggled with this for probably 15 or 20 years, and big pharma's struggled with this on how do you get this reaction to go. And so I'll show you a little bit about what we understand about this now and some other, we think, probably more primary systems to make nitric oxide. And this is really the heart of what we're trying to get at. And this affects everybody in the room, from my kids to the oldest people on the globe. And so what happens is, what we appreciate is, and this is a compilation of data from 4 independent studies looking at nitric oxide production with age. And what we find is the aging process is associated with a gradual decline in nitric oxide production. So it's just part of aging. As Dr. Ross said, with the altitude sickness is acute aging. Well, it's really, if you can figure out how to shift this curve to the right and restore nitric oxide production, then we think, and we've argued, that you can prevent the diseases that plague you later in life. Because we think this loss of nitric oxide activity is what provides this fertile groundwork for plaque development, coronary disease, peripheral artery disease, and even Alzheimer's. So restoring this curve and this nitric oxide production is really paramount for really doing what we're charged to do in academic medicine, and that's prevent disease. Not only treat disease, but really understanding it to the basis that we can prevent it. And so that's what we've been after, is how do we reverse this loss of nitric oxide functionality. And you'll notice here, women before menopause have actually more nitric oxide produced than their age-matched male counterparts because of the positive effects of estrogen on nitric oxide production. And then at menopause, they lose that protective effects of estrogen, and they basically match then the nitric oxide output. And in academia, we're really trained to develop drugs or small molecule prescription drugs. And I show this because really that paradigm is no longer effective and it doesn't work. And this is just some statistics from really the number of drugs that are approved by the FDA. So in 3 years, from 96 to 99, the FDA approved 157 new drugs. But 10 years later, in the same 3-year time period, the agency only approved 74. And out of those 74, there's really been no hallmark therapeutic breakthroughs, no gangbuster drugs that have affected chronic disease. And the reason for that is it's estimated that it takes 10 years and $800 million to take from discovery to market, to go through from they have a basic science discovery and get that through all 3 phases of an FDA trial. So one, it's time consuming, and economically it's not feasible because big pharma is not really able to take on that risk anymore. And so this is basically what we were after, and what I'm going to show you over the next 20 minutes is ways to, and it's really a story of failure, because this is what I was charged to do in trying to develop drugs. And fortunately now we were very unsuccessful at doing that, because the activity that we were trying to isolate was not druggable, but it was actually natural chemistry that occurs in plants. So the frustration in the nitric oxide field has been that 30 years after its discovery and the global acceptance that nitric oxide is one of the most important components of health and disease, there's been no discoveries in terms of therapeutics. And in fact, the only 3 FDA-approved treatments involving nitric oxide are organic nitrates, such as nitroglycerin, that was used long before the discovery of nitric oxide. There's the inhalative nitric oxide therapy for premature babies. And then there's PD5 inhibitors such as Viagra, but these don't act on nitric oxide production per se, they affect downstream of nitric oxide. And as I mentioned, the L-arginine supplementation is ineffective, and in fact, the graph I showed you on the loss of nitric oxide with age is really the ability to convert arginine into nitric oxide. So it's that primary pathway that becomes dysfunctional. So in the aging population, we know that L-arginine is not an effective strategy for restoring nitric oxide, because that's the system that's broken. And in fact, when I mentioned that understanding the complexity of that reaction is very important, in 2006, they actually had to stop a clinical trial where they were giving patients who had suffered a heart attack a high dose of L-arginine, trying to restore nitric oxide production and trying to enhance recovery from that heart attack. And what they found was that the treatment was actually killing more people than the placebo. So that's really, this was a single study, but again, it shows the importance of understanding the complexity of that reaction. You just can't give the L-arginine, you have to give all the other components that support that reaction and make that reaction go. And so as a physiologist, we know that we're taught in many systems that there's redundancy in the human body. There's more than one way to get where we're going if there's a roadblock in one system. But up until recently, there wasn't a recognized redundant compensatory pathway that could overcome this loss of nitric oxide function. And so that's what we've been after for the past 12 years, and I'll show you, hopefully convince you that we've discovered that pathway. And to get the importance of this is why do we spend so much time and resources on understanding nitric oxide availability? Because it's recognized in the medical literature that this loss of nitric oxide function is really the earliest sign of cardiovascular disorders. It's a loss of endothelial function is associated with several cardiovascular disorders. And it's not only associated with those, but it has very predictive capacity for heart attack and stroke. So if you can quantify your nitric oxide activity and recognize what your basal level of NO production is, and if you're low or insufficient, and implement lifestyle strategies, dietary strategies to restore this, then you can do really and cut this off at the source. And Big Pharma has been after this for 20 years, trying to develop nitric oxide releasing drugs or compounds, and they've been largely unsuccessful. And so how do you do this? There's several strategies we can employ to enhance nitric oxide production. As we mentioned, you can give L-arginine, you can give ascorbic acid, folic acid, tetrahydrobiopterin. The problem with that, they require this functional nitric oxide synthase system. And if this system is broken, then you can give these components all day long, and it's still not going to fix the underlying problem. So what we've been trying to figure out is how do we overcome this broken nitric oxide synthase system and give these NOS-independent sources of nitric oxide in a way that's natural, that's found in nature, and it's not a small molecule drug. And we've recognized you can do this through a number of different strategies. One is nitrosyl thiols, where NO is bound to a molecule like glutathione, nitrite, nitrate, which are natural components of the diet. There's nitrofatty acids, where nitric oxide can bind to essential fatty acids like oleic or linoleic acid. There's the organic nitrates, which we know are ineffective at chronic long-term studies. And then Big Pharma has been trying to develop NO hybrid drugs. And so what they'll do is they'll take a standard pharmaceutical such as naproxen or aspirin or even COX-2 inhibitors like the Vioxx and the Celebrex, and then add an NO molecule onto there to try to prevent, one, a lot of the cardiovascular accidents from the drugs like Vioxx and Celebrex, or prevent the gastric ulcerations and the gastric side effects of naproxen or chronic NSAIDs for inflammatory disorders. And this strategy has been very effective in preclinical studies, but FDA one not to approve the lead compound, this naproxen, from a company out of France called Nicox, for safety reasons. And so it's not understood exactly why they voted in such a one-sided vote to not approve these based on safety. But I think that really shook the whole pharmaceutical industry because this was their next whole pipeline of drugs trying to overcome and improve not only NSAIDs, but new class of drugs. And what we've recognized in trying to get to the physiological aspects of nitrogen metabolism in the human body, we go back to the atmospheric nitrogen cycle. So the air we breathe is 79% nitrogen. We've been told all our life that this is an inert compound. So why is the majority of the atmosphere an inert compound that we can't utilize? And in fact, that's not the case because part of the environmental nitrogen cycle takes N2 or nitrogen and converts it into usable forms that plants can use as a source of energy to grow in the soil. This is done through lightning fixation. And so this NN bond, this nitrogen bond, that's N2 that's in the atmosphere, is a very tight bond. So you need a lot of energy to break that up. You can do it through nitrogen fixation or lightning, or there are bacteria in the soil that are nitrifying bacteria. So they can take nitrogen and combine it with other organic compounds and make ammonia, nitrite, nitrate. And when plants are grown in the soil, they'll take up these nitrogen compounds. And then any plants we eat contain these, or any animals that eat the plants that we then eat, we're getting a source of these nitrogen oxides that then the body can use. We're finding out the body can use as a source of nitric oxide. And I think that's demonstrated in the next slide. And so this is a relatively new paradigm, probably 10 years old, where it's recognized, or the pieces of the puzzle really became apparent in the past 8 to 10 years. But it was recognized in the late 70s that nitrate, which is NO3 minus, is actually taken up in the proximal gut of the duodenum. So when you eat green leafy vegetables such as spinach or kale, part of that nitrogen in the form of nitrate is taken up and actively transported out of the gut and concentrated in our saliva glands, or salivary glands. And then each time we salivate, the bacteria in our mouth and on our tongue actually convert this nitrate to nitrite, similar as in the soil. And there are certain bacteria in our mouth that do this. Mammals don't have this enzyme, so we require 100% of the bacteria to perform this first metabolic step. So people who overuse antibiotics, who use antiseptic mouthwashes to get rid of all the bacteria in the mouth, are basically interrupting this nitric oxide cycle. And then the nitrite that's formed in the saliva, once you swallow this, in the acid environment of the stomach, you get a burst of nitric oxide. And this particular nitric oxide that's derived from our saliva, each time we swallow our saliva, has been shown to enhance gastric mucosal blood flow. You can get nutrient absorption. It prevents foodborne pathogens. So if you eat some contaminated lettuce with E. coli, if you have sufficient nitrite in your saliva, you kill off all these foodborne pathogens and inhibits the overgrowth of H. pylori, the most common cause of gastric ulcerations or gastric bleeding. But the problem is people who are taking proton pump inhibitors, but probably the most prescribed drug aside from statins in the U.S., shut down acid secretion, so they no longer have this burst of nitric oxide when they swallow their saliva. So I think the story is yet to be written, but I think long-term chronic use of PPI is going to be associated with a number of cardiovascular side effects as these drugs are on the market longer. So you need, the point is, you need certain bacteria in the mouth to convert this nitric oxide cycle, and you need acid in the stomach. And so without those two, you disrupt this nitric oxide pathway. In this here, I'm going to show you, I think, 2 studies that really changed our thinking on how we affect nitric oxide production. And so these are in animal studies, show proof of concept, and basically we just employed a simple dietary intervention in experimental animals. And so we can give them a low NOx diet with low nitrite, nitrate in their diet, and we can begin to affect blood and tissue levels what we think are nitric oxide metabolites, or markers of nitric oxide activity. And then if we do an add-back experiment, we can basically restore the biochemistry in the blood and in the heart. And then if we subject these animals to a heart attack, we can actually see that they're protected from injury. Next slide. And we can quantify the amount of injury in the heart by looking at the dead tissue. And so the mice that don't have sufficient nitric oxide production through this enterosalivary circulation and through swallowing their saliva actually have less injury or more injury to the heart when they suffer a heart attack. And not only do they suffer more injury, but 50% of these mice will not survive out to 24 hours. So we're not only affecting injury, but also affecting mortality. And then if we add that back, not only do the hearts see less injury, but 100% of these will survive. So showing for the first time that through a dietary intervention, you can restore normal nitric oxide biochemistry in the circulation in the heart, and it's very cardioprotective. You can protect from injury from a heart attack using this strategy. So that was published in the Proceedings in the National Academy of Science in 2007. And then the next study we did, because the reviewers were asking, well, that's fine because these particular healthy mice have a functional nitric oxide synthase enzyme that's generating nitric oxide. So their question was, what happens in the face of nitric oxide insufficiency? So we can use genetic models where these mice don't have a nitric oxide synthase enzyme. And to demonstrate proof of principle, we basically repeat the same experiment and find that indeed these mice are protected from heart attack as well, or from injury from heart attack. And you can see here, this is a cross-section of a heart, and this white tissue is actually dead tissue. And this is unfortunately what happens in humans and patients who have a heart attack. Their heart tissue dies, and so their quality of life and their heart function is very compromised after this heart attack because all of this muscle is dead. And you can see that these treated animals actually have much less injury to the heart, less infarct, as we call it, or necrosis, and then they actually perform very, very well. You can do an echocardiographic analysis of these, and their ejection fraction has changed very, very little. So that was proof of concept that you can acutely intervene in what we call ischemia reperfusion injury, or so if you have a heart attack or a disruption in blood flow, if you have this source of nitric oxide on board, it's very protective to the tissue. But at that point, that's a result of years of bad diet and lifestyle, or maybe some genetic predispositions, where you get that plaque buildup that disrupts the blood flow, or the plaque ruptures and then gets lodged in a cerebral artery or coronary artery, and you have a heart attack or stroke. But the earliest stages of that process is what we call atherogenesis, or the beginning of the process to create atherosclerosis. And that's characterized by white blood cells that become sticky along the vascular endothelium. So these white blood cells and fats will begin to stick to the lining of the blood vessel. They become modified by immune cells, and then over time they actually develop full-blown plaque in the lumen of the vessel. And so it's appreciated that if you can inhibit this early adherence stage, or the adherence of monocytes and neutrophils to the vascular endothelium, you can prevent the development of atherosclerosis. So we did a simple experiment. We basically induce a level of microvascular inflammation in animal models where we feed them a high-fat, high-cholesterol diet. This is well established in the literature. And then we basically give a source of nitric oxide in the drinking water that they can use to generate nitric oxide. And what happens then, we can begin to quantify through intravital microscopy the number of leukocytes that are actually stuck to the vascular endothelium or inside of the blood vessel. And then also not only the number of adherent leukocytes, but how many white blood cells have actually transported or migrated through the vascular endothelium to create this heightened state of microvascular inflammation. And then the next slide is actually a video where we could quantify this. So this is the inside of a blood vessel after a high-fat meal. So this is what's going on with you if you eat a Big Mac and some large fries. You start seeing these white blood cells that stick to the lining of the blood vessels. The blood vessels become very sticky and things start sticking to them. Then you can see a number of cells that have migrated through the vascular endothelium. And so this is what we characterize as a heightened state of inflammation. And really it's the inflammatory component of chronic disease that's really the cause of a lot of this chronic disease, especially cardiovascular disease. And then the next slide is the same blood vessel eating the same high-fat diet, but with a source of nitric oxide on board. So you can see the blood vessel is actually more dilated, it's open, it's wider, there's more blood flow. The white blood cells are doing what they're supposed to do, and so their main role is to home along the side of the endothelium, the blood vessel, to look for sites of injury. So they do that, but they don't stick. They don't aggregate, and they don't migrate through the vascular endothelium. So you can completely prevent the microvascular response to a high-fat, high-cholesterol diet by having a source of nitric oxide on board. And then we quantified a clinically relevant biomarker in the peripheral blood, C-reactive protein, which is a marker of systemic inflammation. Some recognize it as probably the most predictive indicator of heart attack or stroke or risk of cardiovascular accidents. So we can normalize C-reactive protein in the circulation of these animals. And about that time, so we were very excited about the path we were on. And then I was contacted by interventional cardiologist that was trained in China in traditional Chinese medicine. He was working as an interventional cardiologist, doing stents and interventions in Florida, and he didn't like the clinical aspect of it. He wanted to get back in research. So he contacted me and wanted to do a project in the lab about looking at the effects of traditional Chinese medicine that his country's used for thousands of years to treat and actually prevent cardiovascular disease. And so I thought that was easy enough, it was interesting, so I brought him on board. He spent a couple of years with me. And so we sent him to an acupuncture shop in Houston, in Bel Air, and I told him to go get all the traditional medicines that are used primarily for cardiovascular indications. So what do the Chinese physicians give to people that are at risk or have some type of cardiovascular disease or problem, from coronary artery disease to if suffered a heart attack, have hyperlipidemia, high blood pressure, heart failure. And this is what he came back with, probably 8 or 10 different traditional Chinese herbs. And then we began to put them through our nitric oxide analyzer and see if they were working through the release of nitric oxide. And we were quite shocked when we put these herbs to the test. So we have a nitric oxide analyzer that can measure free nitric oxide that's generated from these plant-based products. And what you can see here is once you put the herb in the nitric oxide analyzer, it gives steady state nitric oxide. If we take it out or remove the tubing, it goes back down. So we can actually get predictable, sustainable nitric oxide release profiles from these plant-based herbs and medicines. And then if we begin to combine one or two or three of the different herbs, we can actually quantify the synergistic effect that's been described for hundreds or thousands of years in traditional medicine. So the sum of the parts is greater than the whole. If you combine them, you get this synergistic effect. But what excited me the most is that we could basically dial in any level of nitric oxide we wanted by the rational combination of different forms of herbs and at different ratios. So then we could basically personalize a nitric oxide therapeutic based on an individual's personal needs and how well their endogenous nitric oxide levels work. So we begin to do that and show proof of principle. We combined a combination of these nitric oxide active herbs. And if we take blood vessels from animals and measure the degree of vessel relaxation, if we add the traditional Chinese medicine to the blood vessel preparation, you can see you get a transient relaxation. And very importantly, that if we denude, so if we remove the endothelial layer from these blood vessels, the medicine still relaxes. And so this is very important for people with endothelial dysfunction who don't have a functional nitric oxide synthase. They're still getting a source of nitric oxide that can relax the blood vessels. Very similar to nitroglycerin, but a completely different mechanism of activation. And then if we feed animals for 9 weeks, and this is a genetic strain of mice that spontaneously develop atherosclerosis. You can see here their endothelial function is very poor, so they don't generate very much nitric oxide at all. This is compared to a healthy control animal. Then we can restore about 50% of their endothelial function after 9 weeks in these mice. And then this is an interesting story, again, that happened at the same time. I have a 13-year-old, a 4-year-old, and a 17-month-old now. Well, 4 years ago, when the 4-year-old was born, we were leaving the hospital, had a normal delivery and healthy baby. And then when we were discharged, the nurse goes, well, obviously you should breastfeed, but if not, if your milk doesn't come in, then give the baby this formula. And so being a scientist, my curiosity always runs wild, and I was thinking, okay, what's in the breast milk that's in the formula, or vice versa? What's not in the breast milk that's in the formula? And so after a bit of a struggle, I convinced my wife to come to the lab after we left the hospital to get us some. Because I was wanting to know what was in that. It was different because there's a clear health disparity between formula-fed babies and breastfed babies. And we were interested to see, is there a nitric oxide component to what we were looking at?
We were interested, or you were interested?
She was interested. I convinced her to be interested. And what we found was quite shocking, because what was in the breast milk, the nitric oxide activity that was in the this was still colostrum, and a couple days after birth, was the nitric oxide activity of that breast milk was 20 to 30 times higher than what was in the formula. So with this N=1 observation, I went to the IRB and enrolled, I think we enrolled 72 mothers in the clinic that had just given birth, and we collected breast milk at different times postpartum. I think the next slide will show that. And so what happens in breast milk, the early postpartum days, day 1 to 3, is typically colostrum. And then after day 2 or 3, depending on, it's individual specific, then the transition milk, the milk will come in and it's in a transition phase. And then after about 2 weeks, it completely changes to a mature phase, and the composition of the milk changes. And so we quantified the NO activity of this 3 types of milk from single mothers over a period of time, and found that it's really this early colostrum that has the highest nitric oxide activity. And then, so this was N=1, or a single donation from a single mother at different times, different mothers. So what we were interested in to see if this was just, if that trend continued from a single donor. Is this something that maybe do with individual populations? And so I convinced a couple of mothers to give us serial samples over a period of 2 weeks. And so this is the average of that. And so the trend holds that early on in the colostrum you have high nitrite, but then the ratio of these anions change. And when we understand the involvement of bacteria in this pathway, it makes sense, because babies are born sterile. They don't have any bacteria in their gut. They don't have any bacteria in their mouth. And once we appreciate that bacteria are responsible for converting this molecule to this molecule and then onto nitric oxide, when babies are born and they don't have the bacteria, then nature's developed a way to provide that baby with a source of nitric oxide that doesn't require bacteria activation. But then as the gut becomes colonized over the first 5 to 7 days, then the ratio of these anions change, because the baby then has the bacteria in the gut to do this metabolism of this molecule. And we think we can overcome a number of different neonatal conditions that are associated with breastfeeding, such as necrotizing enterocolitis. And so we've got studies ongoing now to investigate that. And then talking about altitude, a completely unrelated story. So the great thing about putting together talks is you can chronologize these as you wish to make sense, right? And how they fit nicely into the overall story. And so when I was in Boston, we had an anthropologist that contacted us. She'd been studying the chronic adaptive effects of people living at high altitude, primarily Tibetans. So these people live and work at 12,000 feet above sea level, but yet they don't develop altitude sickness. They're laborers, they Sherpas, take mountain expeditioners up to the top of the mountain, and they never get altitude sickness. So she was interested in studying the chronic effects of that in that population and see. So we understand and appreciate their physiological conditions of hypoxia, either through disruption of blood flow to the heart or brain during a heart attack or stroke. There's also environmental conditions of hypoxia. So when you ascend to high altitude, the oxygen's thinner, the partial pressure of oxygen is less. So with each breath, you're breathing in less oxygen. So you're basically giving your body a condition of hypoxia. So she had collected data showing that even though these people were breathing in less oxygen per breath, they were delivering more oxygen per unit time to the tissue. And so the question was, how are they doing this? What's the physiological mechanism for them increasing blood flow in the face of low oxygen? So that's when they contacted us when we were in Boston. And of course the answer is they make more nitric oxide, right? And so we were able to demonstrate that. And so this here is just EPR signal showing nitric oxide bound to hemoglobin. Of Tibetans in the US, there's very little, if any, bound whatsoever. And then if we quantify the nitrite and the nitrate in the plasma, these Tibetans have 50 to 100 times higher these nitrogen oxides in the blood than people that live at sea level. And so again, showing that the ability to generate nitric oxide is what adapts these Tibetans to high altitude and low oxygen. So showing again that if we living at sea level can enhance our nitric oxide production, as we adapt to high altitude, then we can completely avoid altitude sickness. So employing a nitric oxide type therapeutic or dietary supplement, it basically adapts for you, because you're giving your body a source of nitric oxide over time, which then your body can adapt. So the question's been, in not only academic medicine, but even practice, private practice, is how do you recognize and diagnose nitric oxide status in your patients? And so it's not a standard lab you can order, like you can get cholesterol levels, triglycerides, vitamin D, all the end biomarkers that we look at in terms of disease diagnosis. Although we use that in the lab for a number of years, it's not standard clinical practice from LabCorp or any of these diagnostic companies. Really, the only true way to measure nitric oxide production in the body is through a technique called flow-mediated dilatation. So you can use ultrasound, the same ultrasound that you give pregnant babies to visualize and image the fetus. You can do that to the blood vessel. And so if you put a blood pressure cuff and occlude the blood flow into the brachial artery, into the hand for 5 minutes, the typical physiological response is when you release that blood pressure cuff, you get what you call reactive hyperemia. So you get this rush of blood flow that occurs because the downstream vessel is dilated. And that dilates because of nitric oxide production. So that you can begin to quantify the amount of dilation of the blood flow after you release the blood pressure cuff and quantify the amount of nitric oxide that's produced by that particular blood vessel. And this is a typical response. So you can occlude the blood pressure cuff and basically cut off arterial blood flow to the arm and hand. And then when you deflate it, you get this, and you can actually see the blood vessel dilate and begin to quantify. You can integrate the area that is curved and give an assessment of nitric oxide production. So people with poor endothelial function and poor nitric oxide availability, they won't get any dilation of that downstream vascular bed because they can't make nitric oxide for whatever reason. And then this is a study looking at, as you increase the cardiovascular risk load, steady state levels of nitric oxide decrease in a stepwise manner. So patients who have multiple cardiovascular risk factors, by all estimations, have very poor nitric oxide production. We think that's why when you pile on these additional comorbidities, that the patients do very, very poorly over time. So we recognize that, and when I filed patents in 2007, we were able to commercialize some of these discoveries in August of 2010. And with very few people knowing and appreciating what nitric oxide was, from a marketing standpoint, we were very compromised because we basically had provided a solution to a problem that people didn't know existed, right? And so the only way to bring awareness of that is, you need some type of assessment or diagnostic to give people a sense of what their nitric oxide levels are. Had any of you guys ever heard of nitric oxide before this morning? I gave a CME talk in Dallas in September of 2010. 700 primary care physicians, and about the same number of people raised their hand. These are people on the front line treating patients, and they didn't understand or appreciate what nitric oxide was. So understanding now this enterosalivary circulation and the role of bacteria in the mouth, we're able to capture some chemistry on the end of a test strip. And so I think all of you now have a packet, and you have a test strip in that packet. So if you want, you can apply some saliva to that test strip, and you get within 2 to 3 seconds, you'll see a color change. So what we've developed is a semi-quantitative, non-invasive measure of total body nitric oxide availability. So really giving people the first time a chance to see what their nitric oxide levels are. But there's several caveats that you should understand, is that if you've just taken a drink of water or coffee, you basically diluted your saliva. So you want to test, you can either test now or when you not drink anything for 15 or 20 minutes, so you have a nice concentrated saliva set. And so this has been really positive because different people have different levels of obsessive compulsive disorder. So we get some people who want to test many times a day to see what their levels are. But then you've got other people who test once, they'll do our recommended regimen of diet, exercise, or the dietary supplement, and see it increase, and then, okay, they're done. They know that the strategy is effective and they're improving their nitric oxide status. And so we filed 510K with FDA, so this is classified as a home diagnostic. So what I've showed you today is really basic science in animal models. So do we need to be concerned about the foods we eat, and what's the nitric oxide activity or potential of certain foods? Of course, the answer is yes, we should. A kind of a contrived study that was performed by Harshsagar, who was a master's student in Boston, was looking at, so in the Mediterranean region, it's known that the Mediterranean diet is very cardioprotective and has anti-cancer properties. And so we basically just had a contrived menu where we went and collected some really nice, recognized healthy foods, compared it to, I hope this doesn't represent people's diets. And this is being patients of Dr. Ross, I'm confident. But what we did, we grind these up and can measure the NO activity of those foods. really the overall point is that the Mediterranean diet has 20 to 30 times higher the NO potential than the typical Western high-fat unhealthy meal. And then if we go to the store and buy some commercially available juices, pomegranate juice, which is marketed as cardioprotective, heart-healthy beverage, has the highest nitric oxide activity. Those of you who like red wine, you're getting a source of nitric oxide when you sip that nice glass of red wine. I'm a Scotch drinker. Scotch didn't even show up on the profile. I'm disappointed in that. And so with that knowledge, we tried then to develop a nitric oxide index. So similar to the glycemic index that was put forth in the early 1980s to prevent postprandial insulin and glucose spikes, we thought we could develop an algorithm that we could then predict and quantify the nitric oxide activity of certain foods. And so when we developed that algorithm and put the algorithm through the test, we find, not surprisingly, that it's really your green leafy vegetables that are highest in NO index. The kale, the Swiss chard, the arugula. So it's been known for many, many decades that green leafy vegetables, cruciferous vegetables, are good for you. They're cardioprotective. And people have thought it's due to the antioxidant content. But yet when you do antioxidant clinical trials, they always fail. And again, I think it's the combination of the nitric oxide activity combined with the antioxidant profile that provides really this rich source of nitric oxide foods. And so we've quantified probably 400 different foods. We begin to categorize them as high, medium, low. Juices, beetroot juice, which is used in a number of clinical trials now, and particularly in the UK, has a really high nitric oxide index. V8 vegetable juice is a really good source. Then we also recognize that certain ethnic diets are cardioprotective. So we begin to quantify spices. So you can throw some basil or parsley on your hamburger and maybe you'll become a little bit of that. But again, you can see that there are just clearly dietary differences in the amount of nitric oxide potential in certain foods. And so to put it all in perspective, we think we've identified a system where we can begin to manipulate nitric oxide production. So as I showed you before, very early on, people thought that giving an arginine makes nitric oxide. And so for 20 years, we've used these biomarkers as an assessment of nitric oxide activity. Because when nitric oxide is produced, it's gone in less than a second. So it's produced by our blood vessels and it's gone. And it's oxidized by plasma proteins in the blood or hemoglobin in the blood to these intermediate nitrogen oxides, nitrite, nitrate. And then people thought for years that they're just excreted in the urine, excreted in the feces, and then it was the end of the story in terms of nitric oxide. What we appreciate now is there's a recycling pathway that nitrate from particularly certain foods can be reduced to nitrite only if the certain bacteria are present to do this, because mammals can't perform this step here. We only rely on the bacteria. And then we recognize there's some herbs with reductive capacity that can actually take this molecule and regenerate nitric oxide. And this occurs primarily under hypoxic ischemic conditions, which is very important in terms of if you're having a heart attack or you have some type of ischemic vascular disease, such as peripheral artery disease. So they can then have a source of nitric oxide that can overcome this pathway from L-arginine. Then understanding that pathway, and this is a study, so in terms of the Tibetans, we thought that was probably the extreme of nitric oxide production and availability, the upper extreme. Then we were interested in what's really kind of the end extreme in terms of really insufficient or no nitric oxide production, and then what is the consequence of that. And so I have a nephrologist friend who runs a dialysis clinic in Austin, and he was venting his frustrations to me probably about a year ago, 2 years ago, in that people, even though they go on hemodialysis, 70% of them will die within 5 years, although their kidney function, well, they don't have any kidney function, but yet their kidney function is restored through the dialysis procedure. These patients come in every 48 hours, get dialyzed for 4 to 5 hours. The quality of life is horrible. They have no, but they obviously can't stray too far from the dialysis clinic because in 48 hours they have to be dialyzed. But these patients die, and it's recognized that they die from cardiovascular related accidents, heart attack or stroke. And even though you correct for the standard risk factors such as atherosclerosis, systemic inflammation, all the expected risk factors, you still can affect the overall mortality of these hemodialysis patients. So we thought, well, what is the effect of this hemodialysis instrument that basically cleans the blood, removes the toxic waste, and puts it back in the patient's body? So we designed a study to try to figure out what the effect was on these nitrogen oxide metabolites. And our study design was that we collected blood and saliva before the patient went on dialysis. And then after a single pass, so this, this instrument will clean the blood, and it goes through probably 50 or 60 passes through this machine over a period of 4 to 5 hours. So we collected blood as it went through one cycle through the dialysis machine, and then after 4 to 5 hours before the patient came off dialysis, we collected their blood again, which is actually their new steady state levels. And then we compared it before and after. And what we found was quite shocking, that even one pass, first of all, their starting levels of these molecules, which are markers of nitric oxide production, are very, very low to begin with compared to a general healthy population. But what happens is one pass through the dialysis machine, you have about 60 to 80% scavenging of these molecules. And then 4 to 5 hours later, because they have such poor endothelial function, and a lot of times these patients were eating through the dialysis machine, eating tomato cheese sandwiches, potato chips, pizza, really awful food, so they have no way to restore these levels. And so we think that doing this 3 days a week for a period of years, this basically eliminates all their nitric oxide activity, and the reason they end up getting an unstable plaque, it ruptures, and they typically die of heart attack or stroke. So that's what happens in the plasma if we take before and after a single dialysis session. You can see again 60 to 80% scavenging of these metabolites. If we check their plasma, which is what we're measuring with this test strip, you can see that the salivary levels of these metabolites are actually more predictive than what we can pick up in the blood. So we think, and we just submitted this study for publication. I'm hopeful that it will be accepted in Kidney International. But really think we've identified a new consideration for hemodialysis patients. And so there's these filtration membranes that actually will eliminate some molecules and then restore back in the blood of others. And so we're hopeful that we can develop some new technology that can account for that in dialysis patients and hopefully affect the mortality of these patients. So to put it all in perspective in terms of going back to the redundant pathway, we think we have a better handle on nitric oxide production systems in the human body. So it's not to say that that first pathway to be discovered through L-arginine is not working. The problem is it works very well in young age people, and this is the pathway that becomes disrupted with age. But now we've basically recognized a dietary pathway that doesn't seem to be affected by age, but what it is affected by is by chronic proton pump inhibitor use and by certain bacteria in the mouth. And I'm not going to show you the data today, but we've actually begun to recognize communities of bacteria that perform this particular activation. And so we think that patients or humans who don't have these particular bacteria in their mouth, for whatever reason, are disrupting this nitric oxide pathway. We begin to recognize cohorts of patients maybe with essential hypertension that don't have these bacteria. So now we have a new paradigm for basically correcting dysbiosis and introducing certain commensal good bacteria in the mouth that can affect nitric oxide production and really affect disease profile of these patients. So don't take antiseptic mouthwash and don't overuse antibiotics. Better to have bad breath than have a heart attack. And so this is where I put on my company hat, because this is really the technology we developed. The patents were filed through the University of Texas. They own the rights to this technology. We formed a company, and so we've licensed this back from the University of Texas. And we call this Neo 40 because really it's the over 40 population that's really compromised that we think we can affect. And so through a double-blind placebo-controlled study, we did a clinical trial, and so just showing that if we put the lozenge in our NO-analyzer, we can get very predictable sustained nitric oxide release profiles. So this is a spontaneous NO donor, similar to the herbs and botanicals I showed you earlier. If we do put it in a patient's mouth and draw blood every 5 minutes, we can see that we start picking up blood levels after 5 minutes. We get peak blood concentrations within 20 minutes, and this will sustain up for several hours. So it's active. Patients over 40 with known cardiovascular risk factors, after 30 days, we could normalize their nitric oxide output with this particular product. We sent the blood off to LabCorp. They had measured basically everything that they could, because not only were we looking for positive aspects, but we were looking for any potential adverse. One of the good surprising aspects of the study was that patients who had triglycerides greater than 150, we saw on average a 27% reduction in triglycerides after 30 days. And surprisingly, there was no effect on cholesterol, LDL, VLDL, but really, I think triglycerides are really becoming the culprit now in terms of cardiovascular risk. It's not so much cholesterol, because you need cholesterol to make cell membranes and hormones and all that. The other thing we looked at was blood pressure before and after. A lot of these patients were on, I think the average, individual person was on 5.8 medications. A lot of them were antihypertensives. But we saw a 7 millimeter reduction in systolic, 2.7 diastolic in patients who had blood pressure greater than 130/80. This is an image of a lady with Raynaud's syndrome. So Raynaud's is a condition where you have very poor circulation in the extremities. It can be very painful. People have cold hands, cold feet. So this is a thermographic image looking at heat radiating from the digits. 10 minutes after, we can basically restore normal blood flow. These digits start to light up, so again, affecting peripheral circulation. And then so that was all, fine and dandy. Look and see if we could modify cardiovascular risk in older patient populations. But probably one of the most rewarding things I've accomplished or experienced in my 10 years of academic research was really a pediatric patient that came to Texas Children's. So one of my clinician colleagues is a pediatrician and a geneticist, treats kids with a rare genetic disorder called arginosuccinic aciduria. So these kids have an inborn error metabolism, and they don't have, the next slide. So they don't have this enzyme, arginosuccinic lyase. And so as I mentioned earlier, part of the arginine in the body is converted through the urea cycle. So in normal people, citrulline is reconverted to arginine through these enzymes, and then arginine is disposed of through urea or recycled in the body. So if you don't have this enzyme to convert arginosuccinic acid to arginine, you get a buildup of these substrates. So what happens is you get a buildup of arginosuccinic acid. It's detected in the urine of these kids, hence the diagnosis arginosuccinic aciduria. So these kids are typically very well managed by Dr. Lee at Texas Children's. He's the global expert on these conditions. So he contacted me a couple of years ago because he was noticing that as these kids are managed, and their hyperammonemia is actually managed and kept in check, they're developing a lot of collateral symptoms that can't be explained by the underlying genetic disorder. And those include progressive liver dysfunction and cirrhosis. A lot of these kids have to have liver transplants in order to survive in the teenage years or adulthood. They have clotting disorders, a known association with nitric oxide insufficiency. They have neurological dysfunction independent of the recurrent hyperammonemia. So really the underlying problem with these kids is they get a buildup of ammonia in their blood, and it affects their nervous system and cognition. They're developing high blood pressure, renal dysfunction. And so he came to us and said, could this be more than hyperammonemia? Could it be an NO component to this particular disease? And so again, going from bedside to the laboratory bench, we're able to model this. And taking cells from patients, we can see that if we give them L-arginine, they can't convert it to nitric oxide. So the same problem that happens with age, and this is a 13-year-old kid who can't convert arginine to nitric oxide. And I don't think I showed the molecular complex. So what we've identified, and this was published in Nature Medicine a couple of months ago, but what we're recognizing is that you need these urea cycle enzymes to convert arginine to nitric oxide. And so if you give the body citrulline, it's converted in the cell to arginine by the use of these enzymes. It's converted preferentially to nitric oxide. But the treatment of these patients, as you can see here, is you restrict protein, so you don't want to have a high nitrogen source in the diet. They give a drug called sodium benzoate to clear the ammonia. And then you give them L-arginine. So you give 10 to 20 grams of L-arginine to these kids because their body can't make it, so you have to supplement it exogenously. But the problem is that they can't convert this arginine to nitric oxide. So that's what we've been able to address with this particular patient. And so this is a lifetime blood pressure slide from this particular patient. So he was diagnosed at 3 years old. He came under the care of Dr. Brendan Lee, Texas Children's. And you can see when he was 14 years old, his blood pressure was extremely hypertensive despite being on prescription blood pressure medications. And so in February of 2010, he came to Texas Children's. They admitted him to the intensive care unit because his blood pressure was, I think, 182 over 112, 13-year-old kid. We didn't have a commercial product on the market at the time where we could affect this. What we did do was get off-label compassionate use for ISD and a drug similar to nitroglycerin, which, as I mentioned, are very effective acutely, but chronically you can't use them. That's illustrated very effectively here because after 4 days he was released from ICU. taking 20 milligrams of ISD in 2 times a day. His blood pressure normalized. So he went home. He did very well for probably 6 or 8 months. But then over the past 3 or 4 months of that year, his blood pressure started increasing again. Typical with tolerance development for these class of drugs. So February of 2011, almost a year ago, he came back to Texas Children's. By then, we had manufactured this particular product. We modified it for this particular patient because he can't have L-citrulline in the product. So we made him a special product. And I can tell you this is probably one of the most daunting experiences I've had because when Brendan Lee asked me to come in and see this particular patient and consult with his, he had a pediatric nephrologist, cardiologist, his geneticist, and his GP. So I'm in there visiting with the family, being a basic scientist, not a physician, in the presence of these older contemporary conventional physicians. They go, nothing works. What are we going to do with this kid? So when I gave him the lozenge and told him we were going to hopefully lower his blood pressure, really put me on the spot because this is the true test if the product was actually going to work. And so within 20 minutes, we brought his blood pressure down 35 points. And the clinicians were sitting there going, well, measure his other arm. That one's always lower. So a little bit of disbelief. We kept him in monitoring for 4 hours, and they released him after 4 hours. He's been on the product now for 1 year. And his average blood pressure is 112 over 78, off all prescription medications. And so this is this is the emails you get from the parents, and being, again, not involved directly in patient care. This is probably one of the most rewarding experiences. So not only has he managed his blood pressure, but he's beginning to pass state educational exams. Typically, these particular patients have some mild mental retardation and learning disabilities. But this kid's passing exams. He's now beating his dad in chess. So not only affecting the physiological blood flow, but also cognition. So I think that's, I'll conclude with that. So hopefully I've convinced you of the importance of nitric oxide in health and disease, understanding nitric oxide production and availability, and hopefully educating you on diet and lifestyle modifications that can affect nitric oxide. And really we think if you can cut this off at the source before the manifestation of disease, recognize nitric oxide insufficiency early on, then we can really prevent disease. Arginine therapy is ineffective. And again, at the end of the day, what I've told you is still diet and exercise. So it's really nothing that revolutionary, just tailoring your diet and exercise regimen to enhance nitric oxide production. This is a book. I've written 2 medical textbooks. For the technical audience, we found that not a lot of people read that. And really the people that we want to affect is the patient population, the consumers. And so we translated this into an easy-to-read lay version called the nitric oxide solution. This book basically explains in lay terms what I've described here today. And for the more technical audience, we've published a book with Springer Humana Press where we describe this. I've co-edited this with Joe Loscalzo, who's chair of medicine at Harvard Medical School and chief of cardiology at Brigham and Women's. So we put this whole paradigm in perspective in terms of novel ways to regulate nitric oxide production in humans. And then I think the last slide is, obviously I didn't do this all myself. I have a number of people in the lab who do most of the work, a lot of collaborators who have the very fortunate opportunity to work with and bring different levels of expertise, look through the same problem with a different set of lenses, and really allow us to tackle difficult problems in a collaborative effort. So with that, I thank you for your attention. I'll be happy to answer questions.